Most people believe that hearing loss is simply an inconvenience. The volume on the television creeps up, conversations in restaurants become harder to follow, family members start to repeat themselves. The natural response is to nod, to fill in the gaps, to pretend more than you would like to admit, and to put off doing anything about it, often for years, sometimes for decades. I used to view hearing loss as that kind of issue too, a quality of life concern, but not really a health concern in the deeper sense, until I started looking at the research that has accumulated over the past 15 years, particularly the brain imaging studies, the cognitive assessments, the long-term follow-up data on tens of thousands of older adults. Here is what almost no one is told when their hearing first begins to decline. Untreated hearing loss does not just affect what you can hear, it changes the brain itself, it accelerates cognitive decline. It increases the risk of dementia substantially over the long term, and it does this through specific biological mechanisms that scientists are now able to measure and explain. The good news is that this process is not inevitable, and the interventions that protect cognitive function are available, accessible, and increasingly effective. Today I am going to walk you through the actual science behind the connection between hearing and brain health, why this connection matters more after 60 than at any other time of life, and the practical steps that can protect both hearing and cognition. This is not a video designed to alarm anyone. The intent is the opposite. Understanding why hearing matters for the brain transforms the question from whether to address hearing loss into when, because the answer becomes clearly the sooner the better. Let me begin with what hearing actually is, biologically. When sound waves enter the ear, they are converted into electrical signals by tiny hair cells in the inner ear. These signals travel along the auditory nerve to the brainstem, then upward to specialized regions of the brain that process sound, language, and meaning. Hearing is not really an ear function. Hearing is a brain function that depends on signals from the ear. The brain regions involved in processing sound are extensive, deeply interconnected with other brain areas, including those involved in memory and attention, and metabolically active. They use energy, they consume oxygen and glucose, they depend on continuous stimulation to maintain their structure and function. Now here is the central insight. When the input from the ear declines, the brain regions that process sound receive less stimulation. Over time, those regions become less active brain regions in many cases become smaller. This phenomenon, sometimes called auditory deprivation, has been documented in brain imaging studies of people with untreated hearing loss. The auditory cortex shrinks, connections between auditory areas and other brain regions weaken, and the effects do not stay neatly contained in the auditory system. They ripple outward to the regions involved in attention, memory, and executive function, because those regions normally work in tight coordination with the auditory system to make sense of what the ears are picking up. The result is that older adults with untreated hearing loss show measurable changes in brain structure and function over time, beyond what would be expected from normal aging alone. Long-term studies, including some of the largest and most carefully conducted research in cognitive aging, consistently find that untreated hearing loss is associated with faster cognitive decline and a substantially increased risk of dementia. The effect is meaningful. Some research suggests that the increased dementia risk associated with untreated hearing loss may be greater than that associated with several other recognized risk factors, and that hearing loss may account for a meaningful percentage of preventable dementia cases worldwide. There are several proposed mechanisms behind this connection, and they are not mutually exclusive. The first is the auditory deprivation effect already described, where reduced input leads to structural and functional brain changes. The second is cognitive load, the extra effort required to make sense of degraded sound input. When hearing is impaired, the brain must work harder to process speech, especially in noisy environments. This extra effort consumes cognitive resources that would otherwise be available for memory, attention, and other functions. Over time, this sustained cognitive strain may contribute to faster decline. The third is social isolation. People with untreated hearing loss often withdraw from social situations because conversation becomes exhausting. They stop attending events, they reduce phone calls, they participate less in family gatherings. Social engagement is one of the strongest protective factors against cognitive decline, and losing it has consequences. The fourth is depression, which is more common in people with untreated hearing loss and is itself a recognized risk factor for cognitive decline. The fifth involves shared underlying causes, such as vascular factors that affect both inner ear function and brain health. All of these mechanisms can operate simultaneously, which is why the effect of untreated hearing loss on cognitive trajectories is so substantial. Now, let me explain why this matters more after 60 than at any other time of life. Hearing loss can affect people of any age, but age-related hearing loss, sometimes called presbycusis, becomes increasingly common after the sixth decade. By age 75, the majority of adults have some degree of hearing loss. The brain changes associated with untreated hearing loss accumulate over years to decades, which means that catching hearing loss early in its development and addressing it promptly produces better long-term cognitive outcomes than waiting until the loss is severe and the brain has already adapted to reduced input. Time is genuinely a factor here, and the years of life when hearing typically begins to decline are the same years when the cognitive stakes of leaving it untreated are highest. Let me address the practical question. If you suspect hearing loss in yourself or a loved one, what should you actually do? The answer involves several specific steps, in order. The first step is acknowledgement. Many older adults minimize their hearing difficulty for years, often because of denial, embarrassment, or the belief that hearing loss is simply part of aging that does not require attention. Recognizing that hearing matters for cognitive health, not just for daily convenience, often changes that calculation. The second step is assessment. A formal hearing evaluation by an audiologist provides accurate measurement of hearing across different frequencies, identifies the type and pattern of any loss, and creates a baseline for future comparison. Many adults over 50 have never had a formal hearing test, and the assessment itself is straightforward, painless, and often covered by insurance. The third step is intervention when appropriate. For most people with age-related hearing loss, hearing aids are the first-line treatment, and modern hearing aids are dramatically more sophisticated, comfortable, and effective than the devices of even a decade ago. They are smaller, less visible, capable of automatic adjustment to different environments, and connectable to phones and televisions for direct streaming. For specific patterns of hearing loss, other interventions, including cochlear implants for severe loss, may be appropriate. The fourth step is consistent use. Hearing aids only protect cognition when they are actually worn. Many people purchase hearing aids and then leave them in a drawer, often because they were not properly fitted, programmed, or adjusted to the individual user. Working closely with a qualified audiologist over the first several months of hearing aid use, with multiple adjustment appointments, dramatically increases the likelihood of long-term consistent use. There is one more development worth mentioning. The availability of over-the-counter hearing aids has expanded substantially in recent years, providing accessible options for adults with mild to moderate hearing loss. These devices vary widely in quality, and the best results often still come from working with a qualified audiologist, but the lower cost entry point has made hearing intervention available to people who previously could not afford it. If cost has been a barrier to addressing hearing loss, the current landscape offers more options than existed even a few years ago, and a conversation with an audiologist about all the available alternatives is worthwhile. Let me address some common concerns and misconceptions directly. The first concern is that hearing aids are visible and signal age or decline. The reality is that modern hearing aids are often barely noticeable, far less visible than the devices that older relatives may have worn decades ago. The second concern is that hearing aids are expensive. They can be, particularly the most advanced devices, but a wide range of price points is now available, and many insurance plans, including some Medicare programs, provide coverage. The third concern is that hearing aids do not really work. The reality is that they work very well when properly fitted and adjusted, but the fitting process requires patience and multiple appointments, and many people give up before completing this process. The fourth concern is that hearing loss can be addressed later when it becomes more severe. This is precisely the belief that the cognitive research most strongly contradicts. Earlier intervention produces better outcomes for both hearing and brain health, and waiting until severe hearing loss develops misses the window when intervention is most beneficial. Let me also address the prevention side of the conversation. While age-related hearing loss has a strong genetic component that cannot be fully prevented, several factors can slow its progression and reduce the severity of its impact. Avoiding exposure to loud noise, including from power tools, lawn equipment, music played at high volume, and certain occupational settings, protects the inner ear hair cells from damage. Using ear protection in any environment where noise levels are high enough to require raised voices for normal conversation is sensible at any age. Managing cardiovascular risk factors, including blood pressure, cholesterol, diabetes, and smoking, supports inner ear blood flow and may slow age-related hearing decline. Avoiding ototoxic medications when possible, meaning medications known to damage hearing, is important. Some medications are unavoidable for treating serious conditions, but awareness of their hearing effects allows for monitoring and informed decision-making. Regular hearing assessments, even before symptoms develop, allow early detection and intervention. Let me share a story that illustrates these principles. A retired teacher in her late 60s came to me after her family had been gently encouraging her to address her hearing for several years. She had resisted, partly because she felt fine in quiet environments, and partly because she did not want to wear hearing aids. Her family had noticed that she was withdrawing from social events, that conversations exhausted her, and that she had become quieter at family gatherings. She herself had noticed increasing afternoon fatigue and difficulty remembering details of conversations. After a formal hearing evaluation, she had moderate hearing loss, particularly in the higher frequencies that are critical for understanding speech. She agreed to try hearing aids, with multiple adjustment appointments over the first 3 months. By the end of that period, she described the experience as transformative. The exhaustion lifted. Conversations became enjoyable again. She returned to her book club, started attending family events with renewed energy, and reported that her memory and concentration felt sharper than they had in years. None of this is unusual. It is, in fact, a very common pattern among older adults who finally address long-standing hearing loss. Her experience reflects another important point. Many of the cognitive symptoms attributed to aging, particularly the afternoon mental fatigue and the difficulty following complex conversation, are partly attributable to the cognitive effort of compensating for hearing loss. When hearing is restored to a more functional level, the cognitive resources previously used for compensation become available for other purposes, and the experience often feels like getting some mental energy back. Let me offer 4 practical questions worth raising with your doctor or audiologist. The first question: given my age, would a baseline hearing assessment be appropriate even if I do not feel I have significant hearing problems? The second question: if hearing loss is identified, what intervention do you recommend, and what does the fitting and adjustment process look like? The third question: are any of my current medications affecting my hearing, and if so, are there alternatives or monitoring strategies that should be in place? The fourth question: what can I do, in addition to hearing intervention, to support my long-term hearing and cognitive health? Before closing, let me highlight a few signs that warrant prompt evaluation rather than waiting. Sudden hearing loss, meaning hearing that decreases noticeably over hours to days, is a medical emergency that requires same-day or next-day evaluation. Hearing loss in only one ear, particularly if accompanied by ringing or balance problems, deserves prompt assessment. Persistent ringing in the ears, called tinnitus, that is bothersome or interfering with sleep, deserves evaluation. Sudden vertigo, dizziness, or balance problems may have inner ear causes that benefit from prompt assessment. Ear pain, drainage, or pressure deserve evaluation. Any of these can be early signs of conditions that benefit from prompt intervention, and waiting can sometimes affect the long-term outcome. The broader message of this entire video is one that I genuinely hope sticks with you. Hearing is not a luxury function. It is not a quality of life issue separate from health. It is one of the most important inputs to the brain, and when it declines, the brain itself is affected in ways that go far beyond what you cannot hear. Addressing hearing loss is one of the most evidence-based, cost-effective, and impactful steps an older adult can take to protect cognitive function over the years and decades ahead. The research on this connection has matured substantially. The interventions have improved dramatically. The barriers to access have reduced meaningfully. What remains is the awareness and the willingness to act, and that is exactly what I hope this video begins to provide. If you have been putting off a hearing evaluation, please consider scheduling one. If you have a family member who has been resisting addressing their hearing, please consider sharing this information with them. If you have hearing aids that are sitting in a drawer because they did not seem to work well, please consider returning to an audiologist for adjustment rather than giving up. The path between hearing well and protecting your brain is shorter, more accessible, and more impactful than most people realize. Let me also briefly discuss 2 related topics that often arise in conversations about hearing and brain health. The first is the role of sustained mental engagement in supporting cognitive function. Reading, learning new skills, playing musical instruments, engaging in stimulating conversation, and pursuing hobbies that require concentration all support the brain in ways that complement the benefits of treating hearing loss. The brain, like the body, generally maintains what it uses regularly. Older adults who remain actively engaged with mentally challenging activities tend to retain cognitive function better over time. This is not a substitute for addressing hearing loss, but it is a powerful complement, and the two together produce better long-term outcomes than either alone. The second related topic is physical activity. Regular exercise, particularly aerobic activity, supports brain blood flow and has been associated with better cognitive outcomes in older adults. The combination of treating hearing loss, staying mentally engaged, and remaining physically active forms a powerful framework for protecting cognitive function in the years after 60. There is one more practical consideration worth mentioning. Many older adults who get hearing aids are surprised by how much auditory input they had been missing. The rustle of leaves, the hum of refrigerators, the clink of dishes, the subtle background sounds of everyday life. This sudden return of input can feel overwhelming at first, and some people interpret this as the hearing aids not working correctly. In reality, the brain needs time to readjust to processing this fuller range of input again, and the adjustment period typically takes several weeks. Working with an audiologist during this period, with patience and willingness to make small adjustments to the device settings, leads to far better outcomes than abandoning the devices in frustration. The adjustment period is real, it is normal, and it almost always resolves with time and proper support. Everything shared today is general medical information based on published audiology, neurology, and cognitive aging research. Individual situations vary, and any specific concerns about hearing, ringing, balance, or cognitive changes should be evaluated by your own doctor or an audiologist. They know your history, your medications, and the full context that no general discussion can capture. That conversation, careful and informed, is exactly where good hearing and cognitive care begins. Take care of your hearing, treat it as the brain-critical input it actually is, and give yourself the best possible chance for years of clear hearing, sharp thinking, and full engagement in the conversations and connections that make life meaningful.